preparing to live stream the webinar.
Okay.
Yeah, now it's confirmed. The webinar is live streamed, so we can switch off I'm gonna switch off my video and start the webinar.
Okay. Okay. 3, 2,
now
1, and we start the webinar now. Good morning, good afternoon, good evening, everyone. We'll just give a few minutes for everyone to join, and then we'll start. Just a minute for everyone to join. I think we can start now. So welcome, everyone. Good afternoon, good morning, good evening. Thank you for joining this WHO EPI-WIN Wednesday webinar. Today, we have the third webinar on this One Health series, and it's on preventing epidemics and pandemics in the community through the One Health approach, hosted by the WHO EPI-WIN team. I'm Supriya Besbarwa, and I'm the team lead for WHO EPI-WIN, and working together in this team are my colleagues also. For those of you who are new to EPI-WIN, this is the WHO Information Network for Epidemics for Science and Knowledge Translation in Health Emergencies. With these EPI-WIN webinars and associated updates, in which we call digests, our goal is to try and translate science and make it accessible, understandable, and relevant for people to act in evidence-informed ways and make decisions based on evidence in health emergency preparedness and response. Today, we have a great panel of speakers. I'll give you a brief introduction. We have Dr. Sylvie Briand, Director for Epidemic and Pandemic Preparedness and Prevention at WHO. She will provide the opening remarks. Then we have Dr. Petra Khoury, Director at IFRC. We have Yahya Disu, who's the Head of Risk Communication and Community Engagement at Nigeria CDC. We have Miss Erica Marcy, I hope I've pronounced your name correctly, of Kalan from Mexico, and Runa Khan from Friendship NGO, from different parts of the world, giving different perspectives. And moderating this panel with all the speakers is Dr. Maria van Kerkhoff. So before I invite Sylvie to give the opening remarks, just some quick housekeeping. This webinar is being live streamed on the EPI-WIN YouTube channel. It's being recorded, and afterwards the recording will be available from our website, and the address will be on chat. In fact, it's on chat right now. Interpretation is available today. We have human interpretation with our excellent interpreters in French, Spanish, Portuguese, and Arabic. We also have AI-related interpretation in Russian, Chinese, Hindi, and Bengali. So Runa from Friendship NGO in Bangladesh, I hope people from your country will be able to listen in their own language. We invite you to post your name, location, and organization in the chat. We love to know where you're from, and it's great for us to see that this reaches all over the world. Please add any questions that you may have in the Q&A box, not on the chat, because it can sometimes get lost in the chat. And our speakers and colleagues can answer also in the Q&A chat. And without any further ado, I will hand over the floor to Dr. Sylvie Briand for the welcome address and for setting the scene. Thank you so much and welcome, Sylvie. Over to you.
Thank you very much, Supriya, and good morning, good afternoon, or good evening. I'm truly delighted to see the increasing number of participants here today, including those who have consistently shown a deep interest in the concept of One Health. As many of you are aware, our EPI-WIN webinar series has consistently delved into the realm of emerging diseases at the complex intersection of human, animal, and environmental health. With the launch of our One Health series last May, our aim has been to thoroughly explore and dissect the critical aspects of the One Health approach. Today, we gather here to tackle a profoundly important issue, the prevention of pandemics and epidemics within our communities, all through the lens of the One Health approach. When I was tasked with introducing this topic, my mind immediately wandered back to the Ebola outbreak response in West Africa, nearly a decade ago. Ebola, a zoonotic disease transmitted to humans through wild animals such as bats or monkeys, typically initiates its sinister journey in remote villages where people are in close contact with infected wild animals. Outbreaks often begin with a cluster of unusual deaths within these communities. The disease in humans starts with seemingly innocent symptoms like fever, headache, but swiftly escalates to vomiting, diarrhea, and hemorrhage. It then spreads to other humans through direct contact with the blood, secretion, organs, or other bodily fluids of the infected, whether they are still alive or deceased. At this stage, two critical aspects come to light. First, our healthcare workers and family members who initially attend to the patient are at high risk of infection, especially if they lack awareness or access to personal protective equipment or PPE. Second, and perhaps surprisingly, the deceased pose a contagious threat, and certain funeral practices can inadvertently exacerbate transmission within a community. I emphasize these two facets to highlight how a few isolated cases can snowball into a widespread outbreak and eventually an epidemic. But there is hope. We can prevent such tragedies by engaging with community through a One Health approach. This means empowering communities to manage their risks, detect outbreaks in wild animals, and avoid risky contact with infected animals. Furthermore, we can collaborate with these communities to ensure the early detection of human cases, allowing for precautionary measures to protect both family members and healthcare workers in local health facilities, which can otherwise become hotspots for transmission due to contaminated equipment, for instance. We can also work together with communities to develop safe and dignified burial practices that respect local cultural traditions while minimizing the risk of infection among extended families and friends. I recall an instance during a Marburg outbreak response in Angola, where we assisted families in safely handling the belongings of diseased patients, even as they were placed into coffins. Such an approach to safe burials is also applicable to other diseases like plague or cholera. Crucially, establishing an ongoing, genuine dialogue with communities is paramount. providing them with the information that enables them to manage risk and supporting them during outbreak is essential to tailor solutions that work for their unique circumstances and contain outbreaks at source. I must stress that the One Health approach plays a pivotal role in understanding how these communities live and finding solutions that are not only safeguard their health, but also respect the broader aspect of their lives. It's my personal conviction that top-down approaches, often characterized by foreign responders donning intimidating PPE resembling like space suits, can be counterproductive. Instead, approaches grounded in dialogue, empathy, and humility are more likely to foster community engagement and yield effective containment of outbreaks. Each health emergency is unique, stemming from various drivers of spillover from animal to human and a myriad of amplification factors. These factors propel diseases from local to national and eventually global scales. It's indeed possible to halt outbreak at their earliest stage through community-level interventions. And this is why we often stress that epidemics and pandemics both begin and end within our communities. Many outbreaks initially detected through the reporting of unusual clusters of death, surveillance system that operates as a nexus of human, animal, and environmental health enable early detection, facilitating containment at source and within communities, and effectively preventing further amplification. So today, our focus revolves around the critical task of preventing epidemics and pandemics at the community level, all through One Health approach. These EPI-WIN webinars serve as unique platforms where we collectively build a global community and co-create spaces for interaction. In this panel, we will delve into the multifaceted dimension of implementing One Health at community level, examining community protection, research, advocacy, and communication. We eagerly anticipate an engaging discussion and look forward to your insightful question on this paramount topic. Thank you all for joining this crucial conversation. And now I pass the floor back to Supriya.
Thank you very much, Sylvie, for that enlightening, welcoming remarks. Indeed, forming a global community, co-creating with communities to prepare for pandemics and epidemics is critical. I'd like to now request Maria to moderate the next session and invite the speakers to speak. Petra Corey from IFRC initially, who will talk about working in silos and how to work in different with communities in the public health era. So over to you, Maria.
Thank you, Supriya, and thank you very much, Sylvie, for those opening remarks and really setting this theme so comprehensively and so well. And some of the really key aspects which we're going to touch upon today is around prevention. If we're all doing our jobs well, we have the actual opportunity to prevent these outbreaks from happening in the first place. And not only do these outbreaks begin and end in communities, communities actually have the opportunity to prevent this from happening in the first place. And so this engagement and dialogue is not one way. And I think we have 4 excellent examples and diverse examples from around the world to demonstrate how important this is and utilizing this One Health approach. So I'm going to pass it over to Dr. Petra Corey. Petra, I know you can't stay with us for the entire seminar, so we're going to let you speak, and then we'll do a little bit of Q&A before we move to the next speaker. Petra, over to you.
Good morning, colleagues, and thanks for having us and for organizing this EPI-WIN. It's my pleasure to present the work that the Red Cross volunteers do at the community level on One Health. So since 2018 and before the pandemic started, the pandemic preparedness program was launched by IFRC in 7 countries with 7 Red Cross societies, and it was revolving around preventing epidemics from animal source using a One Health approach. And next slide, Maya. Thank you. And through this program, we were able over the past 5 years to train more than 5,000 volunteers who paid 1.5 million household visits. And they were able to identify more than 900 confirmed cases of diseases and prevent outbreaks. How do they do it? They do it through 3 approaches. The first one is health literacy, risk communication, and community engagement. And I see one of the guest speakers is an expert in that area. But the way we do it is we use simple language to provide information, health information, basic health information on outbreaks. And we do that through household visits, community meetings. We recruit key leaders from communities. And sometimes we use media cinema, whatever are the tools that best communicate and reach communities. The second approach is on early detection and early action. And that's using simple systems with two-way communications with health authorities to identify early outbreaks and to have appropriate and timely communication with health authorities. The third one is we work on strengthening regular and emergency health and wash service deliveries. And what we do there is we set up hand washing stations, we construct latrines, we do cleanup campaigns, and obviously a human vaccination campaign, as well as in certain communities, we help establish One Health committees at the community level. Next, please. What I will do is I'll share 3 examples from 3 different countries around the world and how has this approach helped prevent and avert an outbreak. The first one is from Indonesia. It's about early detection of dengue, where the Indonesian Red Cross volunteers worked with health authorities, utilizing community-based surveillance. Through the an online platform, they were able to share alerts, and 84% of these alerts were confirmed clinically and laboratory as cases. The identified cases were referred to health facilities, and this averted death and outbreaks. Following this, in 2022, the government of Indonesia passed a law to allow community-based surveillance and scale it up. Next, please. The next example is from Guinea, and it is the work that the Guinea Red Cross has done in Farana Prefecture, using the National One Health platform. 540 volunteers conducted health promotion and community-based surveillance. And since 2022, they identified 79 dog bites, and they reported those dog bites to authorities. 18 dogs were confirmed to have rabies, and then the victims received the care they needed and no death has been reported. Since then, a database has been created and it has 1,347 dogs established, and they participate heavily on the World Rabies Day to vaccinate dogs. Next, please. The third example is from Kenya, and it's about anthrax, and this is also where the Kenyan Red Cross has done in 4 counties work on health promotion and identified dead animals and proper disposal and averted eating these animals, as well as alerted health authorities and referred people who consumed infected animal products to health facilities. Through this process, and from April to May of this year, they also participated in vaccinating cattle. So 3,600 cattle were vaccinated and 2,000 dogs were also vaccinated over the past, since April, from April to May. They obviously work very closely on the One Health platform with the authorities. Next, please. I have a small 30-second clip, and then we take it for Q&A. Go ahead, Maya. Thank you. All right, and these are certain resources and publications that has more information about the work that is being done at a community level throughout this program and throughout the 190 countries where we have Red Cross and Red Crescent societies supporting communities. Over to you, Maria. Thank you.
Thank you, Petra. Thanks for this presentation, and thanks for giving so many different country examples. I think showing those examples really demonstrates how you utilize this massive workforce that you've and your colleagues have created and nurtured over many, many years. When I heard about this webinar and this topic, I immediately went back to my time in Cambodia and thought of the village animal health workers and the community health workers. And before it was even called a One Health approach, there was this work that was happening together because these local individuals really understood their community. So my question to you is related to that. So what have you found to have been the biggest strength or weakness or challenge, let's say, rather than weakness, in terms of the local individuals who you have worked with, knowing so much more than anyone who can come in from even a neighboring state or province? They really know the animals that live there, and perhaps the mortality of those birds was a little bit off this year than not, or there was something off. What have been your biggest successes and challenges that you've seen in working with communities with IFRC?
Thanks, Maria. I think I'll start with this positive note, the strength. And the strength is that these volunteers and community health workers, they're within this community, they've established trust in community. They're there before, during, and after a pandemic. So they understand the cultural and behavioral and social aspects of their societies and communities. And this is priceless. And when we're talking about losing livestock, when people are losing their income generation and their source of living. And you need to have a trust between the authorities and the community, local actors and the key figures in the communities to get the onboarding of the individuals in the community. So that's the strength that's priceless in my opinion. Challenges, they're on different fronts. One main challenge is that we have to acknowledge that governments do not have a one approach to this One Health topic. There is a siloed approach among ministries between agriculture and health and other ministries, which creates more than one source of information and one source of relation between these community actors and the authorities. This is one. The other one is that there's no one financing approach for this, which is usually a big challenge for community actors. And the financing approach is at two levels. It's the donor financing and it's also the government financing. On the donor financing, the challenges that which we all face is the vertical approach and disease-specific financing, where we doesn't allow us to create a multi-hazardous approach and puts a lot of challenge on how we train the volunteers and how we create these programs. On the government approach on financing, because of the fragmented, not one unified platform, it doesn't allow to have a consistent financing approach among all the ministries. As you said, we have a large volunteer base, 17 million globally, but a volunteer base has turnover, so which creates a lot of pressure on us to maintain the training and the level of education and the level of understanding of this program. And this is also tied into the financing component. So we go back to the funding aspect to it. So having a sustained financial structure is key in the One Health approach. The last challenge is there's a lack of enough animal health workers as well as community health workers, which challenges that the volunteers would send these alerts and they're not investigated in many situations. And it demotivates and disengage sometimes the volunteers because they feel that their alerts are going to deaf ears. So that's also something that they report always back to us.
Thank you, Petra. It's all interconnected, isn't it? And if you're looking at a One Health approach, to only have the volunteer side on the human health aspect and not have it on the animal aspect or the environments in which we share really poses some challenges. But all of those challenges present opportunities as well, as you've highlighted. And 17 million volunteers is really quite incredible. Last quick question before I move to the next speaker. Has the COVID-19 pandemic, in terms of the engagement with communities, has that grown your workforce? Do you see a change from before the pandemic? And is it something that you can sustain? Of course, it's dependent upon financing and many things, but what would it take to really kind of keep that going?
Absolutely. COVID has mobilized the community at all levels. I mean, we've always said that any pandemic requires a whole of a community, whole of a society approach, but it was always talk. It was never talk the walk. The pandemic forced authorities to use this, and we mobilized, obviously, the 17 million, if not more. The volunteer base grew in the last 2 years. Millions, I would say. We were 14 million, we're now 17 million, which spoke to the needs. So maintaining this is very highly dependent on the financing of the programs that we were gonna be able. COVID had abundancy of financing to a certain point. So we hope that this One Health, yes, exactly. So we hope that this One Health approach can also bring further financing, that we maintain. At least there is a certain level of threshold that we need to maintain.
Wonderful, thank you. So this is a capacity that we want to continue, along with our surveillance capacity and testing capacity, but this workforce for community engagement and risk communication, volunteering using this One Health approach needs to be sustained. So Petra, stay on as long as you can. We know you have to leave, but many thanks for joining this seminar. It's always a pleasure to listen and learn from you. Thank you very much.
Thanks, Maria. And when I get off, there's someone from the team that will be there. So if there are any questions and answers, they will take them. Thank you.
Wonderful. Thank you very much, Petra. So we're going to move on to our next speaker, Dr. Yaya Disu from Nigeria CDC. Dr. Disu, I give you the floor. Dr. Disu, we're not hearing you if you have your microphone on. Okay, wonderful.
All right. So good morning, everybody. Thank you very much for this opportunity. Nigeria has 200 million persons well, One Health concept recognizes the existing and emerging threats and opportunities resulting from the interaction among animal, human nature in a shared environment. And leveraging on this knowledge, the key stakeholders foster relationship with shared purpose of well-being of all for both environment, animals, and humans. But we also need to understand that community is a group of people that share common geographical boundary, interest, ideology, or practice. And our people already live interacting with animals and the environment. So we already have the One Health community. Most time interventions do not consider it it's focused on human. One Health emphasizes alignment of efforts, leveraging strengths, and then information sharing as framework for implementation. And that's what you have adopted in Nigeria. And in alignment,
Dr. Disu, I'm sorry to interrupt you. Dr. Disu, maybe I can ask if you can turn off your camera, because we're having a hard time hearing you. I'll turn off mine as well. Maybe that'll help. There you go. Back to you. Apologies.
Is it better now? So we've developed some strategic document, One Health strategic plan, from which we've also have our multi-hazard risk communication guideline that has adopted One Health approach, responding to outbreaks, public health events, complex situations like conflict areas, conflict-prone areas, and also disaster. And in order to build capacity of One Health stakeholders across the level, we've also developed a One Health risk communication guideline, training module, which we have used to train 1L at national level, and currently we are doing that at the community level. And it's important to understand that the strategy we have adopted in Nigeria for community engagement is science-informed, human-centered, data-driven, context-sensitive, theory-based, and community-led. The science tells us how diseases are transmitted from animals to humans and how this happens in the environment. And on the basis of this, how we prevent disease. Then human-centered approach tells us how human behaviors influence disease transmission. And while the data-driven tells us what the situation and how people perceive the situation. The epidemiological data tells us what is happening, who is affected, where are they, and then risk perception tells us how people understand it. And while the context tells us the lens through which we understand things, political, environmental, socioeconomical, technological, and so on. And then while the theory is a framework that tells us, that allows us to understand this situation and also align our practice with the theory. While the community, of course, the epidemic starts and ends in the community. It is the direction that the community moves based on the understanding of the science of that will determine how quickly we can contain this. So that takes us to this slide, which tells us the aim of risk communication and community engagement is to reduce the gap between understanding of science, as in gap between scientists and the community, the way they understand disease transmission. And we therefore bring science to the level of the community through various approaches like drama, the messaging, use of IC materials and SBC materials and so on. And then the more we are able to break it down, the community understand, the more they're able to take ownership and lead in disease prevention and response. And then they do this through the lens of human-centered approach, understanding how the behavior of humans affect disease prevention, and then also build their capacity to be able to interpret data. They are involved in data collection and then also interpretation of this data. And then, of course, socio-economic factors that affect disease transmission drivers are also considered by the community. The theory, we usually leverage on the socio-ecological model, and this allows the community to be able to understand how individual is connected to the families, to the other people, the society at large, and how all these interact to influence disease transmission. Once they understand this, then we know that it's easier for them to be able to take control of disease prevention. Currently, we are piloting human-centered design for prevention of Lassa fever in Lassa fever endemic states in Nigeria. That is Bauchi State, Ondo State, and also Edo State. And then we are at the stage of design and test. We are finished with defined stage, and we started this February 22. Learning from the COVID-19 pandemic, a top-down approach does not work. We now started piloting bottom-up approaches. And we've also used this for monkeypox and some other outbreak response we are responding to zoonotic disease outbreak like anthrax in country. And another innovative intervention is this communication for education, which is a data-driven initiative built on iterative and participatory learning, where the community is involved in data collection. This also uses a machine learning that have used a software for analysis to provide dynamic baseline for informed actions. So that we're building in use of artificial intelligence, and then to be able to tell us what the baseline is like in the last 2 months, so that we will be able to know what to do at every point in time. And the community is involved in this. And then this is the dashboard for community transmission and for community polling for Lassa fever. We have this for other diseases like diphtheria, we have for monkeypox, and then, but this still at the pilot stage. And then all this will also align with the infodemic management data that we are also getting through social listening in the community. We have people in the community who does this. Currently, we are training all the states in the country on the prioritization and then development of key messages for priority zoonotic diseases. So this is the milestone for One Health in Nigeria, in country, coming from national down to community and all the intervention. Thank you very much.
Thank you so much, Dr. Disu. It was, we didn't hear you completely clearly, but your messages came in clear. The slides were very helpful. I particularly appreciate your slide encompassing the human-centered, the data-driven, the science-informed, the context, and the community-led, really highlighting so much of this complexity. It's not just a matter of saying do this or don't do that. It's really about that comprehensive engagement driven by evidence, but led and implemented and adapted by communities themselves, where there's a feeling of empowerment to actually do something to prevent these infections from happening. So thank you very much for your presentation. I'm going to do the next two speakers, and then I'm going to do the Q&A all together. So thank you very much. If I can ask you to stop sharing your screen for the moment. I'm going to move on to Ms. Erica Marce Santa from Mexico. Thank you for giving your presentation on communities' contribution to the One Health Science and Research agenda and the role of education strategies. Over to you.
Thank you very much, Maria, and thank you for all the organizers for having me here today with you. I will focus my intervention on the prospects of incorporating social and environmental dimensions into One Health strategies at the community level. So next slide, please. I represent CALANCAP, which is the Mexican Association for Conservation Medicine, which is a nonprofit organization focused on the disease ecology, conservation biology, conservation medicine, and One Health, whose main objectives are to understand the factors involved in disease emergence and persistence, and to promote integrated human-animal biodiversity and environment well-being through research and environmental education. We recently began, next slide, please. We recently began collaborating in the Yucatan Peninsula in southeastern Mexico with the international joint laboratory called El Dorado, which stands for Ecosystems, Biological Diversity, Habitat Modification, and Risk Emerging Pathogens and Disease Project. This laboratory is the result of the collaboration between the Institute for Sustainable Development of France and the National Autonomous University of Mexico. And in this project, what we are looking is to recognize the risk. I mean, you can see in the slide that we are characterizing pathogen circulation in wildlife and also in domestic animals. And we also are seeking to recognize the system sensitivity. That is, we're looking for the anthropological factors for human exposure and also characterizing pathogens exposure in humans. What we're looking is like, what is the characteristics of the environment that leads to maybe an outbreak? We can see in the picture above, in the draw above, that we can have a healthy community in the right part of the picture, and we can have an ill community where you can have some activities that promote that illness in the community. And also we are looking to seek for the response capacity in order to identify best practices to reduce the vulnerability of the population and a possible epidemic or pandemic process. Usually the scientific and research agenda stops here, limiting itself to identifying the environmental and social dimensions and giving some recommendations that maybe leads to campaigns or to talking with the communities and letting them know what to do. However, for us, this was not enough. So we are convinced that in order to change realities, we have to work hand by hand with communities. Next slide. That's why we have to bring the social and environmental dimensions to the community. With this in mind, we decided to design a community environmental education strategy to be implemented next year. But maybe you will ask, but why a community environmental education? Why not just campaigns and solving the problems right now? Well, because we need community to take action. And for this, we need education for a participatory social action based on care, respect, cooperation, solidarity, equality between people and nature, with social and environmental justice. This is very important in Mexico. We have a long history of interventions. So this is social and environmental justice is something that we need to address when we talk about environmental education for One Health. So our intention is to provide the way and the tools to link scientific knowledge with community knowledge based on their concrete realities, to build community plans for prevention, preparedness, response, and recovery from emerging and re-emerging zoonotic events. Next slide, please. So far, El Dorado project has been working for 3 years in 12 communities of the Yucatan Peninsula in a gradient of land use, including well-conserved area, diversified agricultural system, monocultures, and cities. Due to epidemiological, environmental, and social conditions, we decided to work intensively with 4 communities in Mérida, Tizimín, Caobas, and Calakmul. And they also have this gradient of land use, it is all 4. And we're going to work in these 4 communities to execute the community environmental education strategy. Here at the center of the slide, you can see the factors that influence people, pathogens, relationship, and health disease processes identified by the communities. These factors represent the basis on which we will have to work strongly with community in order to change the social and environmental conditions that increase the risk of an epidemic outbreak. Finally, we can say that the community environmental education approach in the construction and implementation of community prevention, preparedness, response, and recovery plans can help to understand the relationship between societies and nature in a specific context, identify the environmental and social problems of the territory, to increase the community appropriation and engagement for the plans and campaigns and that you promote in the area, and to promote collective action to build bottom-up policies. That it's very, very important. It's what Siri was saying at the beginning of the seminar, and respecting the human right to clean, healthy, and sustainable environment, but above all, to reduce the social, environmental, and economic conditions that endangers human, animal, and ecosystem health, which under the One Health approach, that really means prevention. Well, thank you very much. And I go back to you, Maria.
Thank you so much, Erica. That was a wonderful presentation and highlighting again, sort of the complexities of how important it is to tackle this from a multidisciplinary approach, from a One Health approach. And I really liked how you were saying scientific knowledge and community knowledge. And those are seen as separate things, but it should all be taken together, and that we look at this so that we bring together people's experiences, communities' value, and actually coming together with evidence-based solutions that are implementable and sustainable. So many thanks for that. And also one of your last slides there, highlighting so many of the different factors about how people and pathogens, the environment that we share, come into play, and how this is changing over time. So many thanks for that. I'm going to move to our last speaker, and then we'll move to our Q&A. I just want to remind those of you who are online 2 things. One is all the presentations and the recording will be made available on the EPI-WIN website after that. We're getting lots of questions on that. And if you have some questions for our speakers, please use the Q&A tab, not the chat tab, because there's too much in there for us to go through and find, but use the Q&A and we'll try to pick some questions. We may run out of time. We definitely won't get to them all. So thank you very much, Erica. I'm going to move to our last speaker, Ms. Runa Khan. She's the founder and executive director of Friendship NGO from Bangladesh. Runa, I'll pass it to you to give us an overview, a narrative for One Health, advocacy, awareness raising, and communicating about what is One Health, opportunities and challenges. Over to you.
Thank you. So I have this video playing whilst I'm talking, and it's not a PowerPoint, it's just going to be a video. And if you could start it, I think it's with you. If you could start it, and I will speak. You can look at the video and you can hear me talk. So I started working with One Health for, now it's been 21 years. And for 21 years, it has been a challenge, because I neither realized that the areas that we were working in were, I'm sorry, is the video playing? I'm not sure.
It's starting to play. I don't see it playing yet, but I know that Chang has pulled up her.
Okay,
yes.
in any case, I can continue speaking. And you can hear me clearly, right?
Yes, we can hear you clearly.
Okay. I hope the video starts, because I think that's, it's like it's not a PowerPoint, but it'll, I think, bring you to the scene. So 20 years ago, when I started working in, I did not realize that this would be a kind of a One Health solution. I didn't realize that we were working with climate migrants in the most poorest and the most difficult to access regions in the country. But I knew that if we did not work in a holistic way, so in a sense, I started from kind of opposite of what most people start off with when they start One Health modality. So 21 years ago, I started to ensure that life and community would get a platform and not quicksand on which they could stand, and from where they could take off in a healthy environment, and ensuring that their children grow up well, empowered, and be able to deal with the complexities of nature and human rights. So this was the thread on which I started. And starting on this, we knew that we could not work in a silo. Now, this silo is not a silo of an organization working in a silo, because there was no other organizations there. As a matter of fact, government had interventions, but very little impact happening, because they were just too far away. And it was not a few thousand people. There were millions. We started working at one go with about 10 million people. That was the first step that we took. And we started off with, of course, human health first, because we needed to ease suffering. And it was a human health. So I'll come back to that, human health. But linked with human health, we could not let animal health be ignored, because it was so linked. The children are running around barefoot. So however much we dewormed them, the animals needed deworming to be able, so that the children didn't get the worms, because I found children dying of worms. Then what would they eat? The malnourishment, they were totally malnourished. They had scabies. More than 80% of the children had scabies, and malnourished. So they needed food. Food meant that they needed to understand and know how to deal with the soil, which, with every silt, with every flood, which could happen 3-4 times a year, with every flood, the soil would change. So they needed to work with the soil to be able to ensure that they get the best output, from the soil. So this was a complex ecosystem that you were dealing with, not knowing that actually it's being able to put together, putting the whole thing together would result in a modality of working with climate migrants and working with a solution which was one health for all: human health, plant health, animal health, environmental health, and certainly minimizing pollution of sound and of the air, all inclusive. For example, the boats used, we even have technologies by now, we even have programs and trainings on how to ensure proper maintenance of the diesel engines, for example. We cannot put in electric engine because there is no electricity in the whole area. So how do we work? So the human health, for example, the EPI of children, we needed, it was just too much. The whole thing was too much. It was communities with millions of people. How do you start dealing with this? So we started filling in gaps. How gaps? There was no healthcare. Now, the people didn't even know that they could be cured. So that meant that we needed to perform miracles. Miracles in the sense of a child who could not walk had to start walking. A person who could not see had to see. And fistula problems of women, ostracized society women with one fistula operation going back into society. So we had a secondary healthcare system built. From there came which was quite opposite, like most of the NGOs work, which was we then went from the secondary system to the primary system, the first tier. So the first tier then became the secondary system. Second tier became the community worker, the paramedics who would have to be able to go into the communities and teach people. Healthcare, of course, they were the community workers, the healthcare. Also, going to the third tier where we trained community health workers, and we needed to link the whole system with an mHealth modality so that they could reach not only us, but also the government system, because ultimately that was the goal, that they would reach out to what was available. Then we realized that what happens when you ease suffering? Then they start wanting education because they want hope for their children. Then they want to see that, they want to have awareness because they start working with trying to get their rights. And, child marriages were there. So child marriage, again, gets linked to human rights. So, besides the human One Health solution, we took into consideration the environmental One Health solution. We took into consideration the animal One Health solution. We started training paralegal aids. We start for intervention of carrying security services, awareness, human rights. We have people who, so let's start. So there were the community medics, of course, whom we had to train. Then there were the teachers. There were actually no teachers in that area. So we trained community to become teachers and then linked the teachers to ensuring that training was done on the environment, for the environment, plastic collection, garbage collection, ensuring tree plantation, vegetable gardening, the whole thing. And then food, where would food come from? Soil testing, to ensuring that right agricultural crops were given at the right time. And there was a kind of leguminous plants which were being, which they could use for crop cycling. Fishermen, how to prevent overfishing, which was also very much present. In areas where the mangroves were cut, embankments were breaking, saline water was seeping in. We needed to we created the first flood volunteers in the country, the first paralegal aids in the country, the first parasolar technicians in the country, because you give one, I stopped giving solar panels. Bangladesh has more than 2-3 million solar panels. I started solar panels and stopped. stopped simply because the 2-3 million panels, where are the batteries going? It's not environmental. So we started making solar villages. You've seen some pictures. We started making solar villages. Now we've got several villages where life suddenly started, getting together, and economy started working. And it was a whole kind of the essence of it was working in ensuring that a project doesn't work, but communities start finding a platform on which to work, and which meant a community cannot work without ensuring human, animal, environmental health together. And, we had Bangladesh, after I started the work in 2002, the Bangladesh government then had the One Health Bangladesh in 2008. Then they had One Sustainable Health for All Foundation in 2020, where they dealt with environmental pollutions mainly. However, when we had our One Sustainable Health dialogue, which we had in 2023, this year, in the beginning of the year, we ensured solidarity of all sectors, because it is the only way to be able to bring it to the field. So solidarity of sectors starts with making the people understand, making the organizational staff understand what is One Health, and then making it broader to ensure inter-ministerial bodies, civil society, NGOs, creating a surveillance system, with an integrated MIS, where antibacterial resistance diseases can be identified quickly, and environmental disasters can be done quickly. And this has now been placed to the government to work together. So that's it.
No, that was perfect. And I'm sorry to come in on you. I just want to give a couple of minutes for some Q&A. Thank you very much for this overview and for mentioning the importance of the sectors, and also mentioning the really critical role that we've seen of CSOs in all of this, day in, day out, delivering care and providing services. And the video, when it did work, was really lovely. So it was really nice to see that overview in the work that was ongoing. So there's a lot of questions in the Q&A that are there that we're not going to have time to go into. We'll run a couple of minutes over, since we started a couple of minutes late, but we want to sort of keep to time. So those of you who are speakers who can answer some of those questions in the Q&A, please do so. So I have a couple here that I've pulled out. I'm going to read two questions, and I'm going to open it to the panel to answer some of these. Well, first question is, what role does climate change, migration of people and animals play in the prevention of epidemics and pandemics? How can the One Health approach be used to scale up efforts in preventing the spread of diseases? This says especially in West Africa, but this could be applicable everywhere in the world, looking at particularly weak public health systems and funding. That's one question to consider. The second question to consider is, how do we move away from a human-centered approach to better recognize the value of nature and the importance of changing our interactions with animals and the environment, for example, wildlife trade, intensive agriculture practices. There's lots of questions about agriculture practices in order to improve health for all and to better prevent pandemics. I'm going to start with, let me start with Erica and see if you want to answer either one of those, and then I'll call on some of the others.
Sure. Well, last question is very interesting in what we are doing, because with environmental education, that's what we really are looking for, to change the relationships between societies and nature, and to move from the anthropocentric approach, the human approach, and to change the way we understand ourselves in the world. I mean, we are not about everything, and we really need to understand that we are part of the Earth system. And so changing the view of how we approach to nature, it's very, very important. And also that's one of the main causes for the environmental crisis and the climate crisis that we are facing, the way we approach to nature. So that's, we're working that very hard with environmental education, that just trying to change those those relationships, and also that affects directly to health, just human, animals, and ecosystems health. So I think we are having like a very interesting results working in community environmental educations, just incorporating the local knowledge, and which is very, very important, the indigenous knowledge to this approach. So that's what I will say.
Thank you, Erica. Let me ask Runa, maybe you want to comment on those and then I'll go to you.
I just very quickly, I want to say something a bit different. You know, we are in this world and we are all part of this world. The human beings, the animals, the germs, the plants. And if there is not deep, true respect for it, then we are taking everything away and we are not respecting that. I think if this can be like a little spark in all the studies for everybody to understand, you know, from scientists, decision makers, individuals, that we need to work together and live together, I think, you know, then we are only firefighting every time a disaster comes. So I think there is this which needs to be done, number one. Number two, the food chain. The food chain, if it is locally based, you know, when that makes a lot of difference to when it is internationally and globally based. For example, in the mangrove area, the trees are not harmed if the people who are within that ecosystem harvest the honey, catch the crabs, you know, you know, or take the fruits of the trees. The ecosystem persists, and little trees are cut for firewood. But as soon as the big players come in, for example, you know, then the trees are felled beyond coming back again. The crabs are harvested, they cannot come back again. Right. So there is this in the food chain, I think, which we need to deal with, which is localized system, which is very important. And I think this deep respect that we're all on this one planet and we mustn't harvest everything from this planet is something which we need to internalize.
Absolutely. And the more we can do to prevent these things from happening rather than firefighting, as you pointed out, is the goal, really. So thank you for those comments. Dr. Disu.
Okay, I just want to lay out on what the previous speakers have said. I think we need to shift away from selfish consideration when we look at human-centered approach, because currently we're looking at it on how man can be saved or protected. And then we need to begin to look at how behavior of man contributes to compromising the environment and how it affects the animal. Because you can see that even the climate change effect we're seeing today is as a result of human activity. So human may still be at the center, but the focus needs to shift to targeting those behavior, educating man to understand the implication of what he's doing, how it affects everyone. I know enlightening self-interest cannot be ruled out here. I think taking this to the community level, because community already living in one health, you can't separate them from animals, from the environment. But when we tailor intervention, we focus on man. And I think that is not fair. That needs to change and to consider a holistic approach that will benefit all. Thank you.
Thank you so much. So the team is telling me that we will endeavor to answer more questions, as many questions as possible, even after the webinar, either by EPI-WIN Digest or directly by email. So I just wanted to pass that message on. I want to thank all of our speakers, Dr. Disu, Ms. Erica Marce Santa, Dr. Runa Khan, and Petra Khoury. Before I pass it back to Supriya and the team, just thank all the participants for joining today, for sending your questions, for active engagement. Clearly 1 hour is not enough time to cover this really important topic, which is why we're doing a series of these types of webinars. But thanks for the engagement, thanks for the enthusiasm, and most importantly, thanks for the work. Back to you, Supriya.
Thanks very much, Maria, and a huge thank you to all the speakers as we come to the end of this allotted time for this webinar. And I have to say it was really very engaging and very, very interesting. I'd like to thank, first of all the people in the background who's worked on making this webinar a success. The speakers, of course, to start with, who Maria has mentioned, were amazing, but also my colleague Leticia Siffert, who leads on One Health, Maria, of course, who's been guiding us and has been amazing in putting all this together and bringing all the key issues together. The EPI-WIN team, that's Priya Umachandran, Agnesi Pastorino, Jiangfeng Liu, Gabriela Sentosa, and Tim Nguyen, our supervisor and unit head. But most of all, I'd like to thank Dr. Sylvie Briand, our director and our guiding light, who the EPI-WIN was really her baby. She's been guiding us. It's her that's really wants to get everyone together and engaged for science-informed, community-led preparedness for pandemics. So a huge thank you to everybody, and especially to Sylvie. And last but not least, thank you to all the participants. We've had really rich participation today. And I can see that from the chat that there's a lot of interest in people getting together and connecting further as well. That's something we will consider and take up. Please note that any group that's led by WHO will be announced by WHO, and we will consider this and see how we can get everyone together. And also, finally, to let you know, all the presentations and the recording will be on the website, and we will also next week talk about pandemic preparedness through PRET. So we hope to see you then. And on the week after that, we will have Maria again talking about COVID-19 new variants. That's for September. And in October, we will talk about influenza vaccines and also on Ebola and Marburg prevention. So look forward to seeing you. Thank you very much for your active participation, and we take note of your need to engage further, and we will definitely work on that. Thank you very much. Bye.